Thank you very much for asking me to speak on antidiabetics in NAFLD. I have taken the liberty of removing the word oral because of a publication that has come out yesterday, which I think will interest all of you who are interested in NAFLD and type 2 diabetes. In fact, I think today is a stage where all doctors who treat type 2 diabetes will be very keen to know what are the latest in the management of NAFLD. So without further ado, I will take you to a very interesting slide, which I'd like to show, because the whole discussion, the whole paradigm, the whole narrative over the last 10 years or so has been about CVOTs and heart disease and renal disease. But while the world was watching the type 2 diabetes and CVOTs, the death rate from NAFLD continued to mount in both sexes, is particularly in females, less so in males. So this is what was happening due to NAFLD in type 2 diabetes, because NAFLD is a part of the metabolic syndrome, which includes obesity, type 2 diabetes, and dyslipidemia. And we know the content of liver fat is proportional to the number of components of the metabolic syndrome. In fact, a lot of people have started calling NAFLD as the hepatic consequence of metabolic syndrome. And what does it do? Somehow type 2 diabetes and NAFLD coexist quite frequently to the tune of between 50 to 80%. And what it does is it kind of synergistically worsens each other's prognosis. So NAFLD is independently associated with increased cardiovascular events and also increased risk of chronic kidney disease and proliferative and laser-treated retinopathy. And on the other side, the presence of diabetes leads to worsened outcomes of liver cirrhosis, with liver cirrhosis being one of the highest number of causes of death in patients with diabetes. This is the Italian study. The people with NAFLD have worse fibrosis when they have diabetes. And again, the risk of hepatocellular carcinoma is also increased in patients with diabetes, irrespective of other confounders like alcohol, infections, and geography. So there is a crying need to treat this condition, and until date, there is very little medication to treat both the conditions. There have been certain discoveries and certain serendipitous moments wherein there are certain drugs which have been used to treat this condition, but nothing really concrete has come out of it, and the management has remained quite nebulous and opaque. But the general approach is weight loss really helps with lifestyle modification. Hepatitis vaccination should be controlled. Statin therapy is safe and should be continued. Alcohol consumption avoided, and toxic pharmacological agents must be avoided as well. Other parts of the metabolic syndrome, like blood pressure, lipids, need control, as is good glycemic control. And the indications, again, as I said, are quite nebulous. They're not well established, and the conditions are mainly, the medications are aimed at reducing the liver fat, because it is thought that the reduction of liver fat in turn reduces inflammation, which in turn will reduce the progression to steatohepatitis and thereafter cirrhosis. Now, Utkar is a drug which is very commonly used in our country. It is probably the most common drug that is used to treat NAFLD. And though it is not an anti-diabetic, I thought I should share just a couple of slides on this. It is a secondary bile acid and is thought to have certain anti-apoptotic and antioxidant effects. And this is a summary of all the trials with Utkar therapy for NAFLD. And as you can see, the good goes up from 1996 to 2010, large number of patients. There is no improvement in anything. And if you look at this randomized control trial, which is again a large number of patients with proven NASH, with elevated ALT, and type 2 diabetes with elevated triglyceride and metabolic syndromes, 185 patients, just focus you on the p-value. There is no improvement by the usage of Utkar in NAFLD or NASH, whether the patient has diabetes or not. So let us for once pledge at this RSSDI that we will completely stop prescribing Utkar and not prescribing this in any kind of patients with NAFLD, particularly no role in diabetes. Metformin, the traditionally used drug of the choice in diabetes, is used a lot, and it's first line therapy because it targets the insulin resistance. So it seems like an appropriate pharmacological option. But let us look at the data. Again, the data is from very small studies, about 20 patients, 50 patients, 48 patients, but there have been a large number of studies over long periods of time. There is some improvement in the liver enzymes, but everything else, there is very mixed data. All in all, it seems that as far as the inflammation and steatosis is concerned, there is no improvement with metformin, and maybe there might be some improvement with liver enzymes. So it has minor effects. The meta-analysis showed no improvement, and it is not recommended in non-diabetics, but it does improve insulin sensitivity for all that it is worth. We next come to pioglitazone. As you can see, pioglitazone improves liver histology and fibrosis in patients with non-alcoholic steatohepatitis, irrespective of diabetes. So it improves ballooning, improves fibrosis, improves lobular inflammation, improves steatosis. And this meta-analysis very clearly shows you, with the diamond lying well to the left of unity, that this is something that definitely is a very good drug to treat non-alcoholic steatohepatitis. Now let us look at the combination of these. So this is a study wherein there's a combination of metformin versus rosiglitazone versus a combination of metformin and rosiglitazone. And what are the results? As you would expect, metformin improves BMI and waist circumference, and rosiglitazone does not. A combination of the two of them seems to be improving both BMI and waist circumference. Now we look at the biopsy findings and the inflammatory markers and metabolic markers. The thing is that metformin doesn't seem to be improving any of the biochemical markers except blood sugars, and rosiglitazone seems to be improving the liver enzymes as well as the blood sugars and the HbA1c along with insulin resistance. Now, if you combine the two, again, there is a positive effect on the SGOT and SGPT, and there is an improvement in gamma GT, the transaminases, which are thought to be a marker of inflammation in non-alcoholic fatty liver disease, and it also improves insulin. And finally, if you look at the treatment effect on the histology, metformin has no effect on the histology. Rosiglitazone seems to be having a salutary role, and a combination of the two seems to be having a salutary role. So it seems that glitazones might have some role to play in combination with metformin. However, please look at this paper that we published recently in Nature Scientific Reports, wherein we have reported that the positive effects are completely offset by the harm they seem to cause. This is a meta-analysis of all prospective trials with pioglitazone, measuring its risk and benefits, and it seems that it causes a lot of heart failure, fractures, and anemia, particularly in patients with liver disease where there is a concern about fluid accumulation. Pioglitazone, which is the only glitazone available nowadays, would seem to be coming out more harmful than any kind of positive effect. We next come to the gliptins. The gliptins seem to be showing some improvement. This is a hepatic medicine data from 2018, in which at least these pictures seem to show that steatosis seems to have been helped. As you can see, this is lots of fat-laden tissue which has come down, and fibrous bands near the portal area have reduced with the usage of sitagliptin. However, two randomized controlled trials have found that there is no improvement in any kind of steatohepatitis or liver-related outcomes with the usage of sitagliptin. One thing is definitely known is that weight loss definitely improves NAFLD or NASH liver fibrosis. In a large portion of patients, if they lose about 10% of body weight, they stabilize and 81% regress. And also there's a 7 to 10% body weight loss. There is marked stabilization and regression. If the weight loss is between 5 and 7%, there is some worsening, but largely people stabilize or regress. But if the weight loss is less than 5%, there is not much. So in effect, you should try and aim for at least a 7 to 10% weight loss which is statistically significantly known to reduce NASH liver fibrosis. Body weight reduction is achieved with empagliflozin or other SGLT2 inhibitors. Across the board, you see about a 2 kilogram weight loss with SGLT2 inhibitors. And this is due to the loss of adipose tissue, not from the peripheral tissue, but it is all mainly lost from the abdominal fat. So there is data supporting the usage of SGLT2 inhibitors. And because it causes weight loss, improves glycemic control, and improves the fat mass, it definitely seems a very attractive strategy to try and treat NAFLD. There are multiple potential mechanisms which would suggest that SGLT2 inhibitors would help. It reduces hyperglycemia and visceral obesity, as I said. It reduces oxidative stress, inflammation, and increases adiponectin, and it reduces serum uric acid. And all these things, as you know, would probably have a beneficial effect on reducing NAFLD and reducing NASH. So these are all data on animal models. It's been done with ipragliflozin, remogliflozin, IPRA, Lucio, CANA, EMPA, TOFO. There's also data with dapagliflozin, which shows that there is a uniform improvement of hepatic steatosis in all groups of drugs which have been used in rats and mice. Hepatic fibrosis is improved in a large number of these studies, and a study with tofagliflozin showed a reduction in hepatic cancer in mice by the usage of this gliflozin. Amongst humans, studies are very minimal. We have one very brilliant study from Delhi, from Shafi Kuche's group, Dr. Amrish Mittal's group, wherein there is a significant 16.2 to 11.3%, a highly statistically significant reduction in liver fat in this randomized controlled trial with the usage of empagliflozin. However, the data is restricted to animal studies and very small studies like this. So we decided to proceed with the meta-analysis of the effects of SGLT2 inhibitors in non-alcoholic fatty liver disease with type 2 diabetes, and came up with a pooled population of about 11,000 patients, of whom 7,281 were on SGLT2 and 4,000 were in the control arm. And we were very happy to note that there was a statistically significant reduction of liver fat as well as visceral fat mass in patients who were on SGLT2 inhibitors. We also showed a reduction of weight and HbA1c with SGLT2 inhibitors, though there was no significant effect on serum triglycerides. This meta-analysis provides a convincing signal that SGLT2 inhibitors have a salutary effect on NAFLD in type 2 diabetes. And this is probably driven by an improvement in blood glucose levels and body weight, which in turn would lead to the attenuation of hepatic inflammation and hepatic fat accumulation. And yesterday, as I said, we published this in Nature, the meta-analysis of the effects of glucagon-like peptide receptor GLP-1RA in NAFLD with type 2 diabetes. This is fresh, hot off the press, published yesterday. And this is looked at all the GLP-1 receptors that have been used. There's data with dulaglutide, exenatide, liraglutide with a phase 2 study, liraglutide with a phase 3 study, and also semaglutide with a 72-week study. So there's multiple studies which have been done in comparison to insulin, standard of care, or placebo. And when we looked at this together, there was a definite improvement in markers of hepatic inflammation as evidenced by a reduction of statistical significance of ALT, AST, and gamma GT, the three enzymes which are markers of hepatic inflammation. In addition, when we looked at the liver biopsy data, we found that the usage of GLP-1 receptor analogs reduces liver fat content. There's 3 papers, a total of a large number of patients, of about 500 patients, reduction of liver fat, as well as a reduction in and a resolution of biopsy resolution changes that we have seen. This is specific to type 2 diabetes patients. And also, this was driven by an introduction of body weight and HbA1c. Again, this did not seem to be having any kind of positive effect on serum triglycerides. So to conclude this meta-analysis, we showed that lifestyle modification, GLP-1RA, will soon be a useful therapeutic option. Significant improvement in HbA1c and body weight results in reduction of liver fats, and hepatic inflammation is thus reduced. Thus, NASH is improved. However, it will have to wait for RCTs with liver biopsy or liver elastography before we can compare this. But while awaiting the results of this RCTs, this meta-analysis on a large sample size may well be used to shape guidelines for the treatment, particularly in patients with type 2 diabetes with NAFLD. To summarize, therefore, my entire talk, I'm coming to the second last slide of my talk. NAFLD and NASH, as I have showed you, frequently coexist with type 2 diabetes, each worsening outcomes for the other synergistically. Weight loss helps. Lifestyle seems the only available intervention. Recent papers coming out with bariatric surgery. Pioglitazone improves NASH, but its use is fraught with risk, multiple contraindications. SGLT2 and GLP-1RA lead to weight loss due to visceral fat loss and improved glycemic control, and therefore present a very attractive strategy for the treatment of type 2 and NAFLD. As of now, recent advances show that SGLT2 and GLP-1RA showed marked improvement in transaminases and liver fat, probably mediated by weight reduction and improvement of HbA1c, as borne out by these two recent meta-analyses, but we do need to wait for RCTs. I'll come to my last slide. This is the ADA EASD algorithm, which probably finds pride of place in every presentation that is made during this annual conference. As you can see, it's been used for heart disease, kidney disease, to minimize hypoglycemia, to promote weight loss, and in all other situations. And I will not be surprised if soon there is another slot for NAFLD where SGLT2 inhibitors or GLP-1RA may be preferred. Thank you very much for giving me a chance to speak out here. Thank you.